Good morning, and I would like to thank the organizing committee and TMP committees who are really doing the great job in organizing this event. We are halfway through it. And I would like to especially thank the junior scientists who are here in a very large number, who are contributing to the program with their posters and making this whole thing be on another level of excellence. So, as I said, the organizing committee is trying to put up as interesting program as they can. And today we are going to have here an expert on opioids. So opioids are basically a little bit overlooked in the field of pharmacology, shadowed by monoamines. But there were opioids before there was a pharmacology as a field. And my pleasure is today to introduce Siri Leknes, who will tell you something about it and who is really a world-renowned expert in this field. So we can have an applaud for Siri. And please.
Thank you.
And don't forget to log into your Slido apps, because you will be able to participate in the discussion.
Thank you very much, and good morning, everyone. I'm here today to talk about opioids, which I'm really interested in because they shape our feelings. But I'm also now increasingly interested in them because they are subject to a lot of myths. I have no conflicts of interest to disclose. And in my lab, we are really interested in how the brain and body give rise to subjective experience. And what I'm showing you here is a word cloud generated from a study we run in surgery patients who are on the operating table getting an injection of a large dose of an opioid and telling us what they feel. And you can see opioids lead to a lot of different feelings. And as I said, opioids are also associated with a lot of beliefs. And some of these beliefs have been really harmful. So when I started out in the pain field 20 years ago, everyone knew and everyone told me that opioids are not addictive if you're given the opioids for pain, that pain protects against the addictive properties of the opioid. And unfortunately now, 20 years later, we know that this is not the case. This belief that was prevalent at the time that opioid addiction stemmed from people taking opioids recreationally in a positive state, leading to reward responses in the brain, and then the risk of dependence and addiction, is now supplemented by the firm knowledge that if you take opioids for pain, you can experience relief and you can still develop dependence and addiction. And the whole opioid epidemic in North America is a clear evidence of this. And there are also very firm evidence-based, for instance, studying opioid-naive patients given opioids for surgical pain. And this literature on surgical pain also essentially disproves another firm belief about opioids, which is that we must relieve acute pain to avoid chronic pain. This is actually still a firmly held belief today in much of the pain field, but again, it is disproven by the immense, overprescribing of opioids that has been happening in North America. Essentially, if you could cure or prevent chronic postoperative pain by giving opioids in the quantities that people have been given opioids after surgery, we would see a very marked reduction in chronic postoperative pain in the United States, and we do not. But how about this, which I think for me certainly was the most sort of well-established of all of my beliefs about opioids when I started working with them 15 years ago, which is that opioids are so useful and so prevalent because they are the most powerful analgesics. Well, unfortunately, while it is true that for acute pain, opioids typically outperform placebo. They do not typically outperform non-opioid analgesics. So opioids are not more powerful than the non-opioid analgesics, and I'll show you some examples. The literature contains much less head-to-head comparative trials than I would have expected, given, the sort of just the scope of the problem. But when we do find these studies, and they have been well done, what we see is that opioids are not better than combinations of non-opioids for severe pain in the emergency room, such as acute extremity pain. And you can see here I've actually generated a graph from the Chang JAMA paper just to show you. These are groups of 100 patients who came into the emergency room with very high pain, over 8. After an hour of these different combinations of medications, every group is down to a 6, and after 2 hours, they're down to a 5. It doesn't matter. 3 of these combinations contain opioids, the 4th doesn't. And they're completely identical. The same group has replicated this result. And we see the same thing for acute low back pain when people are treated with opioids over a longer time, if they're sent home with opioids for a week or even 12 weeks. And this paper came out last year in The Lancet. And in this case, they're even comparing the opioid to a placebo. And over the course of a year of the follow-up, the people treated with opioids for acute low back pain for 12 weeks actually did worse. And finally, there are not many high-quality studies on chronic pain, but those that exist show the very clear message that opioids do not outperform non-opioid analgesics in the treatment of chronic pain. But the evidence that I just showed you, these are all oral analgesics. And of course, with opioids, you can also get them intravenously, intramuscularly, intranasally. There are any number of administration methods. So I'm going to show you one more example. This again is from an emergency room, and people are coming in with extremely high, excruciating pain from renal colic. This graph shows the proportion of people who didn't get satisfactory pain relief. And what you can see is that at 30 minutes and 60 minutes after an intravenous morphine dose, we have the least satisfactory pain relief of an excruciating pain. So morphine eventually gets there at 90 minutes, but it's actually slower as well. So I don't know about you, but I find this really shocking, and I think a lot of people, when I started reading up on this, I really, couldn't believe my eyes. And actually, this disbelief is also mirrored in the literature because, these RCTs just don't match up with a lot of clinical experience. And for instance, there's a group in Oslo, in my hometown, that noted this. They do molar extractions, so it's extremely, they get a lot of patients. Many of you have probably had it. And they just couldn't believe that there wasn't an additional effect from giving people codeine, so weak analgesia. And they found this confounding relative to extensive clinical experience. So what did they do? They did a great job. They ran 2 more RCTs in their patients, comparing combinations of non-opioid analgesics with and without codeine. And what they find replicates the other RCTs and contrasts still with their clinical experience. So what you can see here is that with placebo, people really don't get a lot of pain relief from molar extraction. And with paracetamol and codeine, they get a little bit, but the best pain relief in their studies is from paracetamol and ibuprofen. So I think, from just a personal point of view, I think one of the main take-home messages when I started reading up on this is, wow, I've really underestimated the power of, ibuprofen and paracetamol. These are actually great painkillers. But at this point in my talks, people often raise their hand if it's not this kind of a huge audience, and they say, but I've had opioids, I had great pain relief. Well, you know what? So did I. But of course, when we had that opioid pain relief, we weren't in a placebo-controlled setting, so we were open to all kinds of expectation effects. And I think there's a very nice literature in the placebo field showing that if you compare an open injection when you know you're getting an analgesic to a hidden injection, where you're getting the same drug but you don't know about it, we can essentially quantify how much of the pain relief or of the treatment effect, this is not limited to pain, is actually caused by your knowledge that you're getting this treatment. And across all of these studies, we can safely conclude that up to half or even more than half of the treatment effect is typically going to be placebo. And when we say placebo, we mean expectation effects from both the physician and the patient. We mean the natural history, and we mean regression to the mean. So you can see here that the decrease in pain is substantially larger when people know that they're getting treatment. So, to sort of summarize this literature, there really isn't any evidence of that opioids are better for pain relief, but they do work. I'm not questioning that. They just don't work clearly better than non-opioid analgesics. And we see this in the Cochrane reviews, we see this in the number needed to treat league tables and in network analyses that allow us to compare across single drug trials. And the medical field is aware of this in some sense. For instance, Barnett in the New England Journal of Medicine listed this belief that opioids are uniquely powerful medications as a myth and compared it to the reality of the evidence that there is little evidence that opioids consistently outperform non-opioid pain treatments. But there are a couple of ways that opioids really are more powerful than non-opioid analgesics. And it is in their lack of a ceiling effect. So typically with things like ibuprofen and paracetamol, after a certain dose, you're not going to get any additional pain relief. And with opioids, we don't have the ceiling. It means they are extremely useful in the toolbox of any physician. But the other thing that makes them uniquely powerful is their uniquely powerful side effects, which include the risk of overdose death and addiction. So in our lab, we're interested in the effects of opioid drugs, but we're also fundamentally interested in the endogenous opioid system that these drugs target. And one of the reasons that I really believe that opioids would be the most powerful analgesics is because they are known to target the brain's own pain relief system, which was initially elucidated in rodents, centering on the PAG and the RVM, essentially controlling signals coming up through the spinal cord. And then in the human literature, we've extended this to the ROS1-ACC, which acts in concert with the PAG. And I'm citing a couple of really beautiful papers here from Alexander Tinneman and Oliva et al. That combine fMRI with different drug manipulations to really show that these mechanisms are active in humans as well. So when we get opioids, we are likely activating the descending pain inhibitory system. And also, if we look at the PET literature, it seems clear from a series of studies from the Zubieta lab that the people who feel the least pain in his pain studies are the people who seem to release the most endogenous opioids in various parts of the brain. However, in our lab, we have meta-analyzed using this causal method of studying what happens when we block pharmacologically using an antagonist the endogenous opioid system, and we find an effect in the expected direction that people do experience a little bit more pain with opioid blockade, but the effect is really small. There is evidence of publication bias, so it's probably an overestimation. So a Hedges G of 0.18, it's almost nothing. And this is across thousands of people. And actually, this really made me wonder, what's happening? You know, are we not activating endogenous opioid pain relief? So I got in touch with some of the preclinical researchers, and I said, well, what happens when you block endogenous opioids in the rodents? And you know what? Nothing. So we have these mechanisms, but that doesn't necessarily mean that giving a large dose of an antagonist will show, that doesn't necessarily mean that it's always activated. And as you can see from the forest plot here, you know, it doesn't matter if you're asked about the pain intensity or how much, you know, the tolerance, what kind of pain modality, if you're a woman or a man. We've looked into a load more categories. We haven't been able to find any conditions where there really is clear evidence that under these conditions we definitely engage endogenous opioid pain relief. And so, of course, you know, that begs a load of more questions. And I will say that the point where I'm at thinking about all of this is I do believe we have this system, and I do believe we use it. But we have to bear in mind that when we give a drug, it binds, you know, probably indiscriminately to all of the receptors. And we have, you know, a lot of opioid receptors all over the brain. We also have them all throughout the body, especially in the digestive tract. And crucially, the rodent literature has pinpointed a number of other opioid-sensitive microcircuits. This Daniel Castro showed a beautiful circuit where enkephalin release from the dorsal raphe and the nucleus accumbens is necessary. That's what causes mice that have fasted to eat more. If you block this, they don't eat more. We have the habenula anti-reward circuit, which seems to be inhibited by opioids. And Ken Berridge's lab on hedonic hot and cold spots, I think, is especially instructive. So across the rodent brain, they've mapped out these little areas where if you microstimulate with opioids, the rodent seems to enjoy food more. But right next to each of these hot spots is a cold spot where if you microstimulate with the same compound, an opioid, they seem to enjoy the food less. So if you imagine that what you're doing by giving a drug is you're binding to all of these microcircuits and loads more, that perhaps can start explain why the effects that we're uncovering might be variable and numerous. And that gets us into the question of opioid side effects. Because opioids are very useful to treat pain, when governments about 100 years ago started realizing that we need some control over the use of opioids because they are addictive, there was essentially a consensus that we will restrict the use of opioids for the control of pain. And by doing this, we essentially relegated all of the other effects that opioids cause into the domain of side effects. But there are loads of these, right? And I'm going to show you. So there is evidence in the literature that endogenous opioids regulate things like bird song in songbirds. But my favorite centers on catnip. So I don't know how many of you have seen cats sort of all of a sudden rubbing their fur on the ground. There seems to be a specific plant known as catnip that they really like, and they rub their fur into it. And nobody has really known why they've been doing that until a few years ago when Uneyama et al. Showed they were able to find the compound, show that it repels mosquitoes, and then they showed that cats seem to be propelled towards rubbing themselves into the catnip via endogenous opioids. So, sadly, leaving the domain of cats, in our lab we've studied what kinds of actions that opioids seem to propel us to do in humans. And we tested, in our first study, we tested a group of healthy young men, and we gave them both morphine, placebo, and naltrexone on 3 different occasions because we wanted to find behaviors that showed this kind of stepwise pattern, that they would be increased with morphine and decreased with the antagonist, with the blockade. And we had them look at things like pictures of beautiful women. We measured where they looked, and we showed that they paid more attention to faces and explored the faces more with morphine and less than naltrexone. They also seem to value the faces of beautiful young women more, and they work to be able to see them for longer. We see the same pattern when we gave them a really sickly sweet sucrose drink. Then we stroke their arms. This is a really nice experiment, not unlike the pain ones. We stroked their arms gently, and we found absolutely no drug effects on this whatsoever, but we found the same pattern again in a value-based decision-making task where they were playing to gain money. So we do see a replication here of the rodent literature that opioids, endogenous opioids, seem to propel us towards certain high-value actions, such as high-calorie foods or being attracted to high-value potential partners. And we've recently meta-analyzed a different aspect of reward, sort of more going into the social domain, because with Panksepp and his theory that opioids are so addictive because they hijack the sort of attachment circuitry, there is a literature assessing whether if we block endogenous opioids, if people feel less connected. So we've meta-analyzed this literature, and we find a small effect, which you'll be interested to hear is still bigger than the effect we find for physical pain. And what we don't know, and I'd be curious to hear what you think, is whether this is a small effect that doesn't matter, or if it's a small effect that could accumulate over time. So one interesting, sort of and slightly promising pattern that we see in the data is that the effect is slightly larger when we ask how connected people feel to loved ones compared to strangers. But on the other hand, and maybe relevant to this audience, in opioid use disorder, when they are treated with antagonists over months, extended-release naltrexone, we haven't been able to find any evidence that their social function is impaired at all. If anything, the patients will say, my life is so much better now, and my relations are so much better. So we don't really know if these small effects that we seem to see on reward behaviors, if they actually, how much they matter over time and in the sort of in the case of disorders. But given that we see this sort of association with reward, you might believe that maybe this other firm belief about opioids that they cause euphoria, at least that should be evidence-based, right? Well, wrong, at least in our hands. In our lab, across a number of studies using both oral drugs and IV drugs, we really don't see that people's mood is improved at all when we give them opioids. And this started, got me thinking. I was like, maybe we're just not using the right drugs. We should be giving people heroin. And thankfully, I never had to try that with the ethics committee, because actually that was done in 1955 by Louis Lasagna and Henry Beecher. They tested 20 healthy, normal subjects in a lab setting, and they gave them 5 different drugs, one of which was intramuscular heroin. And this is a quotation from one typical participant. He felt irritable, shaky, unsteady, nauseated, and angry at the doctor for making him sick. So not at all what I grew up hearing, if you try heroin once, you're going to be addicted for life. Well, I think probably this guy won't be. And on average, they found that they had slightly positive mood effects with placebos, with benzo, and really positive effects with amphetamine. But both heroin and morphine were slightly dysphoric in the sample. And then if we move over to the endogenous opioids and we look at the blockade literature, both in our own lab and basically across the whole literature, it's really firmly established that if you are a healthy participant and you don't have a drug use disorder or alcohol use disorder, your mood will be just fine, even if I pharmacologically knock out at least 90% of your opioid receptors. We have, however, not stopped there, because these are all placebo-controlled studies in the lab, right? So they're not ecologically valid. But we work with a lot of anesthetists, and we started asking patients on the surgery table, in a high-stress situation, you're about to be cut into, we started asking them how they felt before and after they got a large dose of an open-label opioid. And guess what? They feel slightly worse. So we see this across remifentanil and oxycodone in an open-label study, and then we moved into an RCT where they know they're getting an opioid, but we're comparing morphine, oxycodone, and fentanyl, and we replicate the pattern pretty much exactly. So overall, if we look into the individual variability, we have between a quarter and a third of people feeling better, and we have approximately a third of people feeling worse after we give them a dose of an opioid. And these are, intravenous drugs, and they're definitely feeling the effects. And actually, this pattern of really large individual variability, you can see in these graphs that, there's complete crisscrossing, and they're using the whole scale, right? That actually matches what we see in the pain field. So I made a histogram here of, this is from the largest lab study of opioids that I know, from Martin Angst. And in 228 people got a shot of alfentanil in a really controlled way, and then they had super controlled pain testing. I'm showing you one of the outcomes here. And you can see that on average, there is a clear benefit of the opioid. They tolerate the heat pain for more than a second or two longer. And there are a few people, at one end who really seem to be benefiting a lot, tolerating up to 5 seconds more. But then the people on the red there, they're actually not getting any benefit of the opioid at all. And we see a similar pattern in real life. This is from the emergency room data that I cited before. You can see some people are getting full pain relief, some people's pain is worse a couple of hours after they get different combinations of opioids and non-opioid analgesics. And the problem with this is when you're on the operating table, you don't want to know what the mean effect is. You don't want to know what the number needed to treat is. You want to know if you're going to be among the red people or you're going to be among the other extreme at the blue end. You want to know, is this going to work for me? And you also would like to know, how many side effects am I going to get? And at the moment, we don't have a way to predict that except by giving you something and then asking you. So that's not ideal. So that, since I'm at ECMP, led me to look into some literatures in the psychiatry field. Of course, there is plenty of variability in the rest of psychiatry. So I thought, well, let's look into the depression field. And I really love this study from Stone et al., where they got hold of all of the data from antidepressant trials submitted to the FDA. So it's individual data from 12 weeks of treatment in over 73,000 people. And the overall reduction on the HAM-D scale is 10 with the active treatment and 8 with placebo. So the debate still rages, because the people who think that antidepressants are not very effective will say the difference is 2 on the HAM-D, that's nothing. We should stop giving people these medications. But the people, who feel that, this is a really useful way to treat people will point to the distributions and show that there is an over-distribution of placebo improvement at the low end, around 0, and there's an over-distribution of really big improvement from the active treatments. So this might be a way to start looking at the opioid data to try and get a handle on, what's actually happening. And then there's a different field, the dopamine and sort of cognitive effects field, that also have started really, working hard to try and identify the good responders. And I've been inspired by this work from Roshan Kuhl's lab, where she studies the baseline dependency principle for dopamine drug effects. So the idea is that individual differences in striatal dopamine synthesis capacity, which I have to say is really hard to pronounce, explain variability in cognitive effects. And they see this, they pre-registered it, they see it across methylphenidate and sulpiride, and they see it replicated across indirect and direct measures, so working memory capacity or dopamine PET. So if we go back to opioids, what determines how opioids act? Well, certainly, because there are so many different drugs, we have to look at what drug it is, what dose it is, what administration method. The context and your expectations are clearly important. as are who you are and what your experience is. So I think one of the main reasons that these beliefs about how opioids work are so fixed is that there is plenty of evidence on opioid drug effects from people who are already opioid users. And usually, if you taste coffee and you start liking it, you're going to drink it every day. And then, if I ask you, do you like coffee, you'll say yes. And we see a kind of a similar, effect, of course, with opioids. If you already like opioids, you're going to say you like them if you try a new one, or you're more likely to. And of course, opioids are known to cause very severe withdrawal effects. So these are also hard to disentangle in opioid users. And then there's the issue of pain relief, because most of you, if you've had opioids, and I'm sure many of you have, you will have had a great effect, and you'll think, oh my God, I love opioids, And I used to think that. But actually, maybe what you love is pain relief. Because if you're in really high pain, personally, I love anything that takes me out of high pain. And that doesn't mean that I would really enjoy it outside of a pain context. So we have looked into individual sort of predictive factors in our surgery patients. We're launching a large research program to continue this in the thousands of patients that we're now recruiting. But in our initial samples, what we see is that it seems to matter whether you've had opioids before. So in our first sample, our opioid-naive participants who reported never having had opioids before, they were very unlikely to feel better. But if they'd had opioids for more than 2 weeks, and this is a relatively small group in our Norwegian sample, they were over 4 times more likely to have this mood boost after opioids. And we also are very interested in the effects of stress. And there's an interesting literature in the opioid field on early life stress that I won't get into. In this case, we had the measure of stress just before on the morning of the surgery. And it seems that if you are increased, your negative affect of the morning of the surgery is increased 1 point, then you have a 9% increase in the chance of getting a mood boost and a 12% decrease in the chance of feeling more anxious. So this is something we'll be looking into, but I'm going to talk in the final part of my talk. I'm going to talk about another firm belief in the opioid field that I'm now starting to question, and that is does it actually matter if you like the drug? So intuitively, it makes all the sense in the world, right? If you like something, you're more likely to want to take it again. I mean, this is partly the function of subjective experience. But then I invite you to think back to the first time you tried coffee, cigarettes, or alcohol. Did you enjoy it? Probably not. Did you still continue? Probably yes, right? So there isn't necessarily a clear one-to-one relationship, and that's actually what we find in the lab. So we ran this study where the hypothesis we wanted to test was whether stress, experiencing an opioid in a stress state, as you often do, if that would increase the abuse potential because you would experience relief. And we tested this by inducing stress in our healthy volunteers using the Trier task, which is a fake job interview, and a math task. And because we ran this repeated measures, we also, the second time they did stress tests, we actually had them sing in front of a judging panel. And only 3 participants walked out, which I think is amazing. I personally would never do this. So after we got them in a stress state, we gave them an IV dose of oxycodone that we titrated to make sure they felt high. So this is placebo-controlled, but we do want them to feel the effect. And then we measure whether they feel any relief by affective state ratings, heart rate, and cortisol. And then the crucial bit is we actually gave them the opportunity to work to have the drug again. So we specifically asked them, so you've had the sampling dose, how much of this effect would you like in your second dose? And then they had to work and press buttons like a little rat for a few minutes to achieve it. And we ran this, double-blind, placebo-controlled, and overall 252 sessions across 63 healthy volunteers. So, just to show you that their manipulations worked, we got them reasonably stressed, as you can see from the early peak, and then we had some repeat stress tasks. We got them feeling quite high, and we elicited, a large cortisol response. And then we tested the hypothesis, would they want more opioids after stress? And at this point, this study was really hard to do. It happened during the pandemic. Everything was a little bit of a nightmare. And I have to say, I couldn't believe my eyes, because we actually confirmed the hypothesis. We have this effect. But then we continued to run all of the pre-registered analyses, and it turns out this isn't the result. This is the result. Our male participants really wanted opioids after stress compared to the control condition, and our female participants didn't. So this is a very large sex effect. And so we see this stress increased drug wanting in men, and it's specific to oxycodone. We don't see in the placebo condition. So, of course, we went back to the data, and we were like, well, maybe, did the men get more stressed, or did they get more stress relief? And interestingly enough, they didn't get more stressed. They actually got a little bit less stressed. The women show clear sort of increase in both subjective and heart rate responses to the stress induction. So that doesn't explain the result. And then really, oddly, they also didn't get more stress relief or buffering of sort of subsequent stressors. Actually, they didn't get any stress relief at all. So what you're seeing here are the ratings for embarrassment, which is the strongest effect, because the subsequent stressor is a video where we tell them how we will judge their performance in the stress task. And this sort of gets people, feeling very self-conscious, and so they get embarrassed at exactly the same level with oxycodone and placebo. If anything, the women show a little bit, they don't show any clear evidence of stress relief, but they do show a little bit of buffering. But of course, they didn't want any more opioids in the stress condition. So what we actually think that we're seeing is a direct effect of the opioid on the motivational circuitry that doesn't rely on the subjective experience. And while we didn't have a specific hypothesis that, that we would find this effect only in men, it's interesting to note that injection drug use is 3 times more common in men than in women. So to sort of summarize, we confirm the main hypothesis, but we also show that it seems to be completely independent of the subjective experience. So to sort of give you the take-homes, I really think that opioids are overrated, both for pain, for mood, and for stress. I think it's really a concerning point that opioid prescribing is more eminence-based than evidence-based. We can't predict who will get good analgesia and who will get safe and tolerable side effects. But opioids nevertheless alter behavior, in sort of quite concerning ways. And I think the time is now to consider individual differences. So it looks like I have 2 minutes left. So now I'm going to show you a pattern that I personally find extremely concerning, and I hopefully will maybe inspire some of you guys to go into opioid research as well, or maybe implementation. Because if we look at opioids from a historical point of view, we find opium poppy seeds in Stone Age archaeological finds. They're really common. It seems that sort of Stone Age humans really prized opioids, and they're linked to both pain relief and the very sort of universal human desire to get high. And then we crystallized morphine in 1805, and it's hailed as a cure of pain and opium addiction. That didn't work out, but they synthesized heroin, and they market it as a non-addictive cough medicine. 100 years on, you're starting to see a pattern, right? They improve OxyContin, and it's aggressively marketed as a non-addictive formulation, and leading to the ongoing opioid crisis. But surely now we've learned, right? Well, I mean, I really hope we have, but I am concerned because in 2020 there was a paper from a set of emergency doctors in the United States, and they compared oxycodone and morphine in the emergency room. They had really great motivation. They were concerned that they were making people addicted by giving them oxycodone in the emergency room. So they thought, let's try morphine. And the reason they wanted to try morphine is they thought it's non-addictive. So, and you know, this is, like, I don't mean to, this is just an example of all of the, you know, problematic beliefs that are still so prevalent in the opioid field. So with that, I hope I've inspired you and shocked you a little bit, and I want to thank my collaborators and my team in Oslo. Thank you very much.
Well, I would like to thank you very much for this very interesting and inspiring talk. As you might guess, we have quite some questions here. Some of them you have already answered during the talk. One of the more voted and interesting ones are, can you please comment on the studies that have shown that opioids relieve psychic pain and lower suicide attempts in people with suicidal thoughts on the short term?
Well, so in our studies, we don't see any clear evidence that opioids help with sort of the emotional pain that we induce by making people feel like they're failing at a task. But of course, this is in a very controlled setting. And in studies of, for instance, chronic pain patients who are treated with opioids over time, they will self-report that opioids help them manage their emotions, you know, strongly. So I think either there's a subgroup or this is an effect that emerges over time, because today I've primarily talked to you about acute opioid effects, and the extent that we can extrapolate from acute effects to chronic effects is, yeah, it's probably very limited. I think the opioids probably change the brain and the body in ways that mean that the effects are quite different. I think Panksepp was very keen on using buprenorphine primarily to prevent suicide, but I'm not super familiar with those specific studies. I think, you know, you really have to consider the risks as well as the benefits.
Yeah, this was interesting in terms of also comparison to ketamine, which also kind of was given in such circumstances. One more question here. Could part of the large inter-individual variability in opioid response be due to the differences in pharmacokinetics and opioid receptor drug occupancy, or differences between different opioid receptors?
Yes. So we don't have a lot of tools to study the effects on different opioid receptors, unfortunately, in humans at this point. There is an antagonist, that mu-specific, that Glaxo own. And if anyone knows anyone at Glaxo who can get me access to that antagonist, let me know. I would really like to use it. It would be an amazing tool to be able to compare the mu-specific antagonists with the non-specific antagonists that we can use today. But we do believe that most of the typical opioid analgesics primarily target the mu. And the other question was about the pharmacokinetics.
Pharmacokinetics, exactly.
Yeah. Well, you know, there are the known genetic effects of, you know, that are specific to codeine, and I think tramadol is also subject to some of these. We don't see, when we compare, for instance, you know, fentanyl, oxycodone, and morphine, we don't see very many effects consistent with the importance of pharmacokinetics, or actually very large differences between these drugs. But we are looking into it further.
Yeah, thank you very much. So for the sake of time, we will have to wrap up at this point.